So this fellow fell off a building, landed on the sidewalk, crowd started to gather, cop walked over, looked down and said, "What's going on here?" The guy sat up and said, "I don't know, officer, I just got here myself." So I figured we'll warm up the crowd a little bit. So the subject we'll talk about is shrinking plaque. And I think in the business and marketing world, we're sort of tormented by everybody shrinking the serving size, the packaging size, and stuff. But plaque is something that if we are able to shrink it, it would be great. And I think for quite a while there was conflicting evidence on whether that was possible. But I think data has shown it is possible. Although how to translate that into actual outcomes is something that people are still arguing about. And what I mean, and this is something that people who are involved in clinical trials really argue a lot about. It's one thing if you could take a picture of a blood vessel and you can show that the amount of plaque is getting less in that blood vessel. But actually, what you're really interested in is by using that same kind of treatment, can you actually show that you reduce the risk of a stroke or the risk of a heart attack or the risk of dying? So when we look at clinical trials, what we really want to see are what they call outcomes: heart attacks, strokes, mortality, rather than what the clinical trialists call surrogate endpoints. And a surrogate endpoint would be shrinking of plaque in a blood vessel. With that kind of as a background, a little bit of an introduction, it's still, to those of us in the field, we think if you can show that plaque stops getting worse or even shrinks a little bit, that's a pretty good surrogate endpoint. And probably if you can do that long enough, you'll probably start to see a reduction in events. So what we're looking at is not the shrinkage of plaque, the shrinkage of ice cream in a serving size, but whether we can actually get plaque to shrink, that's narrowing down a blood vessel. And we'll step back a little bit. Unfortunately, I don't have a pointer, but we can sort of look at the pictures there. A little bit of background. When we talk about plaque building up in arteries, and the arteries we concentrate on are the arteries in the neck, the carotid arteries that feed the brain, or the coronary arteries, the little blood vessels that feed the heart muscle. But there's a process that you don't really consider this a normal process of aging, but it definitely progresses as people get older. And that's this hardening of the arteries, or the development of atherosclerosis. And so when we're born, our blood vessels have nice, thin, smooth linings. Blood flows through them freely. But over the years, and again, and aging is just one of the things that leads to injury of the lining of the blood vessel. But basically anything else that can damage the lining of blood vessels, like cigarette smoke, or high sugars and diabetes, or high blood pressure, or high cholesterol, these are things which are constantly working on that lining to get cholesterol from the circulation into the tissue underneath the lining of the blood vessel. So as the cholesterol and triglycerides get into the wall of the blood vessel, it leads to a lot of local irritation and inflammation. The cells that line the artery respond to that inflammation. They start to multiply. And there's a whole complicated sequence of events that leads to this deposit of cholesterol in the vessel walls, the surrounding inflammation, the response of the walls and the blood vessel, and it starts to narrow. Over time, that even starts to calcify a little bit. So you actually get hard calcium in there, and that's where a pathologist who would take one of these vessels out during an autopsy, if you squeeze them, they'll crackle. You'll feel something like an eggshell in there that crunches. That's the calcium that builds up. So over time, this plaque really starts to narrow down blood vessels, and when it gets that bad, it starts to interfere with blood flow to the organ that it supplies. So this is the atherosclerosis process. And depending on which organ or which tissue is deprived of its blood supply, that could lead to either heart attacks, strokes, circulation problems in the legs. So this is something that we would really like to avoid if we can, and certainly if it develops, we'd like to be able to make it get less or go away if we could. And I can't tell you how many patients ask, is there some kind of a pill that's like a roto-rooter, can clean out the blood vessels? And so keep that picture, what we showed, in mind, and we'll kind of tell you how this all works. We talked about the plaque and what could lead to its development, and all these risk factors. The one that we have no control over, and we sort of joke about what's the best way to prevent heart disease, is to pick your parents wisely, because the cholesterol levels to a great part are determined genetically. The smoking, that's our fault. If we smoke, it's nobody's fault but our own. High blood pressure, again, it's a process of aging. There are things we can do to keep blood pressure under control to help. And diabetes, again, as if people tend to become overweight as they get older, sugars tend to rise. So again, diabetes risk is sort of under our control. Aging, we'd like to age. No problem with that. I'll just mention, because we'll talk a little bit about these different kinds of cholesterol particles in the bloodstream, what these are, so you have an idea, kind of put it into context, because as we talk about preventing, regressing, or stopping plaque, it has to do with affecting cholesterol levels in the bloodstream. So when you get a blood test and you get these results back, the first assay that's run on the blood is a total cholesterol. So it's basically measuring all the cholesterol that's in that sample of blood, and they're reported out in milligrams per deciliter. So the numbers range, from 150, 160, 180, 200, 210, 220. Those are the total cholesterol readings in the blood. Cholesterol doesn't travel dissolved in blood like sugar and water, because if you think about it, cholesterol is kind of a fat. And fat and water doesn't mix. So actually, if you took a sample of blood and let it stand for a while, you'll see the cholesterol and triglycerides all rise to the top, just like cream that's not homogenized would. But cholesterol travels in the blood, and actually little particles. You can see these particles under a electron microscope. And they're particles that are surrounded by little proteins, and the composition of things make these particles soluble in the blood. And these particles have different densities, so that some are denser than others. And scientists who deal with these, who discovered these and then named them, were very, very creative. They named them according to the density. So they have high density, low density, and very low density lipoproteins. HDL, high density, LDL, low density, and VLDL, very low density. Scientists are really creative. And triglycerides, which are kind of travel in the same company as cholesterol. Remember that triglycerides are not the same thing. Triglycerides are fat, and cholesterol is a kind of molecule that's actually used in cell walls and in certain hormone biosynthesis and stuff. But so anyway, they all travel in particles. And it turns out that, as cholesterol travels in the bloodstream, and some is traveling from the liver out to the body to be used, and then some's traveling from the body back to the liver to be recycled. So there's a sort of constant traffic. The LDL particles are the ones that take the cholesterol that you eat, processed by the liver, put into these LDL particles, and then travel out into the body to be used in tissues, in blood vessel walls and things. It's these LDL particles, these are the bad ones. So these are the ones that are taking cholesterol out to the periphery, and under the wrong circumstances, these particles get through the lining of the blood vessel into the blood vessel walls and start to accumulate there. So the metaphor that I like to use for LDL particles is like the little dump trucks. And they're carrying cholesterol out and dumping them into the vessel walls. The HDL particles, the high-density lipoproteins, are the good guys. These are like little scavenger backhoes that take the cholesterol from the vessel walls and travel it back to the liver, where it gets taken out of the bloodstream and excreted in the stools, in the feces. So if you think about it, there's a constant traffic of LDL going out and HDL coming back. And it's the balance of those two that determine whether or not plaque is laid down or not. So, you think about it, and when you get that blood sample measurement, you'd like the LDLs to be as low as you can. That's the traffic heading out and carrying the cholesterol to the vessel walls, and the HDL to be as high as you can. because those are the little reverse scavengers that are bringing the cholesterol back to the body. And so it's affecting this balance that plays a role, actually, in the risk of developing and the risk of progression and maybe regression of this plaque. Right? So with that as background, then the question is, well, how do you detect plaque? And this is a subject of a whole another set of discussions and things. But the ways that people are looking to see during these clinical trials that look at plaque, if it's getting worse, getting better, they really are trying to look at blood vessels in a precise way that can be measured. So this is actually, they're looking at blood vessels in ways that are a little more precise than what gets done in the routine coronary angiograms, where the numbers are kind of estimated but not really directly measured. And the early researchers in these fields kind of set up that process. This is a still frame from a coronary angiogram where a catheter was inserted into an artery, advanced to the heart, and little bits of dye were injected into the blood vessels that feed the heart. So this would be the dye running into this blood vessel, and you can see all the branches that are outlined just by the dye flowing through the vessels. And this is actually a pretty normal artery. Now, if we look at this one, you can see, and normally the arrows are not there during the angiograms, but this was put here afterwards. You can see that vessel narrows down almost to a little thread there. And so you look at this and say, well, number one, that's not normal. And we'd look at that one and say, well, you know, to our eye, it looks about 85, maybe 90% narrow. And that's how a clinical angiogram would be reported if you had one done at the hospital. The people who are involved in these clinical trials actually used computers to outline the normal vessel and then draw lines around the narrowed spot, and to actually have the computer calculate a percent narrowing that's actually pretty precise. They call this quantitative angiography. This is one technique that investigators use to look at plaque and decide, is it shrinking or is it getting worse? So that's how you can tell, you know, what's happening. There's another technique that's similarly invasive but doesn't use dye. And I'll show you a picture of that afterwards. But the general idea is that you can now measure what blood vessels look like before and then after an intervention and see if it does any good. Now, there were a few studies that specifically looked at the coronary arteries. And interestingly, the first one, which some of you may have heard the name Dean Ornish, the first one was run by a fairly controversial guy out on the West Coast who believed fervently that if you were strict enough, I mean strict, with diet and risk factor modification, that you can stop atherosclerosis in its tracks. And he published a paper which was well documented. This is a really strict low-fat diet. It was very difficult to get people to adhere to it. And the other thing which is important to know is that not everybody who follows this kind of diet will see the same dramatic lowering of LDL cholesterol. So the numbers went from an average LDL of 146 down to 86, and that's a drop that we would normally say you could not achieve without using cholesterol-lowering medications. It turns out most people can't. It's just the genetics of it. But if you select a group that actually will respond to very strict diet modification, and you stop smoking, which was one other little thing that happened to a number of these patients, and you meditated a lot, and you know, a whole series, these were lifestyle changes too, he was able to show that the plaque shrank about 8% in people who followed this regimen and achieved these goals, versus getting worse by about 28% in people who were the control group. This was very impressive. It was first solid evidence that you could actually see plaque stop getting worse and even shrink a little bit. And it actually didn't involve any medications, which was, again, a sort of controversial conclusion. And I think the only other point to make of this is that, again, number one, most people can't do that. And I can't tell you how many folks have gone on possibly not as strict of a regimen, but have really cut back their diet, exercise, lost weight, checked their cholesterol, and it went from 220 to 190, 220 to 210. You know, drop, but not very much. And that's, you know, that's just the way our bodies are. They just, you know, they're programmed to manufacture cholesterol, and they don't respond dramatically to diet. But if you could get into that range with diet and exercise and lifestyle changes, chances are the plaque will stop getting worse and maybe shrink a little bit. Now, the other point to make is that 8% decrease in diameter, or 8% increase in diameter because we're shrinking plaque, that's not that much. And actually, and admittedly it isn't, but the one thing to remember, and I'll just go back a couple pictures to that plaque picture. One thing to remember is that for physicists and mathematicians in the audience, if you change the diameter by a little bit, remember the actual volume, the actual area, changes by the square of that diameter. So actually, little changes in diameter are squared. So actually, the change in diameter are a lot bigger than you might think by that little change in diameter, number one. So the blood flow will actually increase quite a bit, even though the diameter doesn't change very much. Number two, even though the flow doesn't change a lot, what you're actually doing when you shrink plaque is the globs of cholesterol that are in there, that's actually what shrinks. That's what gets smaller and goes away. So the plaque actually changes characteristic. All the multiplied cells don't really change. The calcium that's there can't go away. The fibers and scar tissue doesn't go away. But what happens is if you're able to shrink that blob of cholesterol, there's less tension on the wall of this plaque, less tension, less of a likelihood that lining of that plaque will crack, will rupture, and form a clot there. So one thing we're able to see in these instances, the plaque changes characteristic and the risk of an event goes down a lot. And the symptoms change quite a bit, again, just because the diameter and the area of flow changes. So even though 8% may not sound like much, it actually has important clinical effects that are quite beneficial. And maybe what's even more important is that it's not getting worse. The other criticism, but it's the reality, is that the number of patients in this study was very small, 48. So when you're dealing with small numbers of patients, it's always possible that by the play of chance you might see a beneficial outcome, where if you did the same study with 1,000 patients, it might not show that benefit. But this is the data. Now there was a determined investigator named Dr. Brown, who we've had the pleasure of actually meeting and working with, he was convinced that lowering LDL cholesterol and raising HDL, so again you're talking about now, you're affecting both streams of traffic, would be beneficial in preventing plaque from getting worse and shrinking it. So, and you can see by the date here, this is in 1990, the medications available to us, or to him in these studies, have evolved over the decades. So this was a tough study to do back in the day, because I don't know if any of you have used cholesterol. You probably not even heard of it. These are still available in different forms, but it's a powder. It's like Metamucil sort of, but it's a resin that you have to take a scoop out, put it in a glass of water, stir it up, and drink it down. It's sort of a gritty, sandy taste to it. It passes through the intestine and it binds cholesterol in the intestine. So it actually doesn't even get absorbed at all, which is kind of a neat property of medications for people who are intolerant to some other ones. You know, we still have a form of this available today, but it's a pain to take. And in those days, you'd be taking 2 to 6 scoops of this stuff spread out over the course of the day, and then combining that with niacin, which is very tricky medicine to use, especially in those days where this was not the long-acting niacin that we have as a prescription drug. This is short-acting niacin, so people had to tolerate all kinds of hot flashes and things. And then lovastatin, that's Mevacor, that was the first commercially available statin. So he used a combination of these 3 agents and was able to cut the LDL cholesterol down by almost 50%. Now, just as a sidebar, we can do that with Crestor or Lipitor now. It's a lot easier, but that's how they had to do it in the 1990s. And raising HDL with the niacin. So using that this combination of medications, he was able to have pretty substantial changes in the cholesterol makeup in the bloodstream. And he was able to show, also using quantitative coronary angiographies, actually Dr. Brown really perfected that technique, showed that in the control group, plaque got worse in almost half the people, but in the therapy group, about half of the number of people who had progression was cut by half, and about a third actually shrank. Event rate was reduced by almost 2/3. Now, event rates, we use the word event, that's a euphemism for stroke, heart attack, or dying. And mortality was cut by a really big amount. This is very impressive. The only thing to remember, again, is that the number of people in this study was small. That's small by clinical trial standards. So again, there's one criticism of this trial is that, yes, but the results, this could be results just by the play of chance. But it looked pretty encouraging. So the markers that you look at, the plaque progression, stopped getting worse. And as you would expect, the event rate dropped. And he repeated this study, again, about 10 years later, using, he used a different combination of medications, niacin, still the short-acting form, and simvastatin, that's Zocor. And we look at 20 milligrams and say that's a pretty small dose of Zocor. But he was able to get a fairly similar drop in LDL cholesterol and a bigger rise in HDL cholesterol. Statins raise HDL a little bit, and then the niacin works along with that. And on average, you could see in the treatment group, in the control group, the plaque got a little worse. And in the treatment group, the plaque stopped getting worse and actually improved some. And the same thing he saw. There was a reduction in events in this group. Again, same criticism. These are hard studies to do if you think about it. People are taking a complicated collection of medicines and they have to volunteer for coronary angiograms. The first one was done for a regular indication. They were having chest pain. But the second one, which was done a year or two later, was done just for let's look and see. So the patients who signed up for this were basically were committed to proceeding to develop this knowledge. So it's a hard study to do. But again, it pointed it in the right direction. That that we are able, with aggressive control of lipids, to shrink plaque and reduce events. And the last study I just wanted to show you, and this is using a different technique, was looking at the carotid arteries. And they used a technique called intravascular ultrasound, which is kind of neat. If you imagine a catheter, and a catheter is just like a long IV, very flexible, about the gauge of a strand of spaghetti. And if you imagine at the tip of this catheter, there's a little ultrasound chip. So if you can imagine, when people have sonograms and they have these microphones that are on the chest or on the stomach taking pictures. If you imagine this microphone reduced to a little chip on the tip of this catheter that's threaded through an artery, threaded up into the carotid. And so this picture, if you can imagine this very dark spot in the middle, that's the catheter. And it's sending ultrasound out in all directions. So the rest of this is the inside of the blood vessel. And you're looking at the blood vessel from the inside out. And I'm not sure how well it projects on the screen. In a blood vessel that's completely normal, it would look circular, and the lining of the vessel would be pretty thin. And instead, what you're able to see here is this dense stuff here. That's calcium in the blood vessel wall, and down around the bottom, it's sort of a thicker area that's not quite as dense as this. This is one of those mixed plaques that I was saying, where there's some globs of fat in there, there's the multiplying muscle cells, some fibrosis, not the hard calcium. And it's interesting when you talk about what plaque is the more dangerous, which is the one that might crack, form a clot. It's actually the soft plaque that's the more dangerous ones. These tend to be stable. This, if you want to know the buzzword people use these days, is called vulnerable plaque. So anyway, this is how you can actually take a picture of an artery from the inside. And if you think about it, this is probably more accurate. If you were able to see the lining of it and draw a line around it, it's more accurate in terms of measuring the percent diameter, you know, how narrowed or how open a blood vessel is. So this, again, this is a similar study where people had to volunteer to have this done twice. Once at the beginning and once further on down the line. It's harder to do. But what they did was looking at carotid arteries in these patients. They thread the catheter up into the neck and taking the pictures from the inside out. There's no dye involved, but it's still kind of an invasive procedure. And what they were able to do in this group of patients who were on statins already and who had carotid artery disease, they added either niacin, which helps lower LDL and raises HDL, or Zetia, which helps lower LDL. And they compared the two groups of patients to see what happened. And interestingly, you can see in the Zetia group, hardly any change at all over the course of this study. And the study lasted about a year, which was a kind of criticism because these changes actually do take longer to evolve. But even in that short period of time, there was a pretty substantial decrease in the plaque diameter in the carotid arteries. So this is, again, now this is looking now at another vascular bed, but the similar concept. If you can affect the cholesterol aggressively enough, chances are that you're going to see the favorable changes in plaque. And I'm getting a time signal from the back, so I'll just add one thing that's different from last year. Last year we were anticipating with great excitement the results of the AIM-HIGH study, which was a clinical trial, 3,000 patients, aimed at looking at outcomes in individuals with vascular disease who had their LDLs controlled with statins and who had low HDL cholesterol. Half these people were given niacin, now the contemporary niacin, the long-acting form, and the other half were given a placebo. And we all expected, this was actually Dr. Brown designed that trial, it was run by the National Institutes of Health, we expected this was going to be a big benefit. And if you're used to looking at these outcome studies, where the bottom line is the time of the study over years, and this is the event rate. This was the event rate of the patients who received placebo, and lo and behold, if you add the niacin group to it, exactly the same. No change at all. So this was a surprise to everybody. And I'll just say, you know, it does not mean that the prior studies were wrong, although it makes us stop for a minute and say, in patients who have vascular disease, low HDLs, in whom the LDL is really well treated, so I'll tell you the average LDL in this group was 70. These were really well treated patients, and most of them had already had bypasses and stents. In that population, there may not be much extra benefit in raising HDL, but the other point to make is that the HDL only went up on average 4 points. So it actually wasn't much of a rise. And the last point that the British, who criticized this study quite roundly made, was that the population, which was 3,000, may not have been big enough to show a fairly small benefit in this population.
When they did the thing in that little chip, did they knock you out, or are you awake?
You're awake. Little sedation, but you're awake. But anyway, so I think is to sort of wrap things up. I mean, the book is not closed on this whole topic. There are some sub-studies from AIM-HIGH that are being looked at where they're actually looking at carotid plaque composition and things. I think with attention to risk factors, hopefully we won't even get to that point where we're looking to shrink plaque. We can probably prevent a lot of plaque with good attention to cholesterol, HDL, LDL, not smoking, etc. But if we do get to that point, we think we've seen clinically the ability to stop the disease from progressing and maybe even regress a little bit. So I'll stop there, and I think, are we totally out of time? No time for questions? If you have questions, I'll be out back. Thank you very much.